Coming up today, a young life lost to suicide, how one family is channeling their grief into change. And stick around for this nice story to wrap up the week. See which player brought joy to some of our youngest patients. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Right off the bat, we want to let you know that today's discussion is about suicide. It can be difficult, even traumatizing to talk about, but there is hope. And silence doesn't help anyone, especially now when suicide rates in the U.S. are at an all-time high. The most recent CDC data is from 2022, and it shows that suicide rates increased about 35% between the year 2000 and 2022. 49,000 people died by suicide in 2022. That is one death every 11 minutes. Suicide attempts and the number of people who report thinking about suicide are much, much higher. But the statistics don't show us the real people impacted by suicide. Every death and every attempt has a far-reaching impact. And today we are meeting someone who ran into some roadblocks while trying to get help for her son. And in the years after his death, her family has made it their mission to improve mental health services for people here in our area and beyond. We'll also ask what can be done to help people before they reach a crisis, including kids who may face extra stress as we kick off this new school year. Joining us here in studio, we have Dr. Mitchell Douglas, a psychiatrist and the medical director at the University of Kansas Health System's Marillac campus, and inpatient children's psychiatric hospital. Always good to have you here, and I know they're very, very passionate about this, so glad to have you with us. Across from me, we have Stacy Stoltz, a licensed clinical social worker and the health system's clinical manager of mental and behavioral health services. Great to have you here and your insight. Thank you. We're also happy to be talking today with Kelly Speck. Her family founded Carl's Cause in honor of their son who ended his life in 2017. And we're going to hear about the very real life-saving impact that Carl's Cause has made here with the health system. So good to have you, Kelly. Your husband, Bob, couldn't be here, but we spoke several years ago, and it's just nice to have you here and still pushing through with Carl's Cause. Carl was diagnosed with bipolar disorder during his sophomore year of college, I remember. He is not defined by that diagnosis or the suicide that happened back in 2017. Let's talk about Carl. Tell us about him and what he was really like.
Yeah, well, some of the pictures that keep coming up, I'm like, oh gosh. Because he really was just an all-American boy, you know. He was smart and athletic and kind and had a ton of friends. He'd never had a depression diagnosis at all growing up or any kind of mental health issues at all. So it really wasn't until his sophomore year at K-State when it came on out of nowhere.
I hear you sounding kind of like the typical parent, the typical family. You got a kid going off to college, nothing to even be worried about. More looking forward to some exciting things. But in 2010, you learned that he was living with bipolar disorder. What led to that diagnosis? Was that an easy diagnosis to get?
Yeah, no, I mean, it came out of the blue, and it was a mental health crisis is what he faced. And that was our first time at learning about it, and also trying to get help for him that very first time. We didn't know where to turn or what to do.
How'd you know something was wrong? Was he talking about it, or were there signs that you noticed?
Yeah, I mean, with the mental health crisis, everything kind of stops normal in their world, and he was not thinking right. He was not himself. He was like erratic behavior, some things that just weren't typical at all.
Did your mind go to, gosh, he's in such desperate help that could he take his life? Were you even thinking that?
Not at that
like
point
a typical parent, you would not even, that would not be on your radar. So you try to get Carl help. Where were you searching for answers?
Well, you know, we got him home. He was at K-State, and we got him back to Kansas City and took him to one of the local medical centers, thinking, okay, let's get him to the hospital because he needs help. And within like an hour, they released him, and you know, he hadn't slept. He hadn't, you know, he needed some support, and we were given no information. Plus, he was over 18, so they wouldn't even talk to us in the room or let us have any involvement, which we weren't. That was the first time too we'd ever been faced with that.
Well, you said talk about the ultimate roadblock. He's your boy.
Yeah.
But he's 18.
Right. Well,
So now you're having trouble. But he's over the age of 18.
Yes.
You're trying to get him help, and now, what other roadblocks were you facing? Did it feel like in the moment?
Just, I mean, I didn't know, there weren't any resources. I didn't know where to turn, who to call, like how to find any information. And you're in the crisis mode at the moment. He's there in our house and we're trying to talk, like what do we do? What do we do? And what do we not do? And it was very difficult.
Dr. Douglas, what is bipolar disorder?
So bipolar is a complex psychiatric diagnosis defined with episodic, longer periods of mood instability. So a child can present as doing fine, or an adult, doing well, euthymic would be the term, and then they have what's called a manic episode, where there suddenly is significant and abrupt change in mood and behavior, where they'll do things they normally would never do, act in ways they would never normally act, distinct change, and that can last days to weeks in a row, followed subsequently by perhaps a period of normalization where everyone's like, oh, what was going on there? And then may also be associated with a significant depressive episode as well.
So I would imagine there are a lot of people, kind of put it into perspective, how many people you think might be living with something like that, but it's not diagnosed.
Yeah.
You just think this is how someone is.
Super hard to diagnose. It can be very challenging, especially if you have that younger adolescence and like sort of that older adolescence, excuse me. So if you've got someone who's 19 or 20, they're doing college stuff. And sometimes it can happen too where you have people in their early 20s, they're having this episode where they're engaging in erratic behavior, stuff they never do before, and they might do illicit substances. So now you have to figure out, is the problem a bipolar illness or is it substance induced? So it can take a while, and there's lots of data talking about the time it takes to make a proper bipolar diagnosis.
Well, and so many factors. You're right. He's off to college.
Yep.
You never know. There's new friends involved. You never know if there's substance abuse.
Yep.
There's stress from school.
Yeah.
They're just kids. And
That's just
you
kids.
say adult, but I see kid.
You see
I
kid,
say
right.
kid. That's a kid to
And he's
me.
20 and he missed classes for 2 weeks. Is that
Right.
Is that something we should be worried about from a psychiatric illness standpoint, a bipolar standpoint? Should it be concerns for an anxiety disorder?
Right.
Or could it be he just doesn't like to go to class?
Exactly.
It can be so tricky. And especially if the child or the younger person doesn't want to disclose what's really going on.
Right.
We're going to be talking about Carl's cause throughout the program. Tell us what it is, Kelly. How did you come up with the idea to do this? Why was that so important to you and Bob?
Yeah. Well, so right after we lost Carl, which was the summer of 2017, and by then he was 27 years old. So he had kind of a 5-year grace period after the initial onset, and then it came back kind of with the force 5 years later, and then these last 2 years were hard. So after Carl passed, we were all sort of in a free fall, I call it. I mean, our family, we were just all thinking, how are we ever going to survive this, and what are we going to do? And we didn't know what to do. But my husband Bob kind of came up. I mean, he said one day, he was like, we have to bring mental health awareness to the stadium level. It was kind of his thing he put out that we all went, oh my gosh, that's what we got to do. We have to do that, because if we felt like if Carl would have been able to talk about it, if it was a more normalized conversation, or if we would have even known this could happen to somebody like him, like it's not people who are on the streets, or like at a certain, sometimes we think it's a certain type
There's
of person.
Stereotype
There
of
is,
what
there
mental
is.
health is.
Yeah,
Mental
yeah.
health
Yes,
occurs to
yes.
everyone. I'm sorry to interrupt, but
No,
it
you're
occurs
right.
everywhere.
Yes, yes.
Everyone, every socioeconomic status, every
yes,
race, every
yes,
gender
yes.
has the chance to
Right.
you can suffer from mental illness,
Right.
and everyone
But
needs appropriate treatment.
and we had no idea that was the case at all, until it happened to us. So
what does Carl's Cause do? What are they doing, and what does that outreach look like in the community?
yeah, well, at the beginning we weren't sure what we were going to do. We really just thought, let's just bring awareness. We'll do awareness events, and then kind of by circumstance, my husband's brother manages a golf course. He's like, we're going to do a golf tournament. And at the time I thought, oh, I don't want, if we start raising money, then we've got to figure out the responsibility of that and what we're going to do. But one thing led to another, and we did get connected with the great people at University of Kansas Health Systems Behavioral Health Center, and they were getting ready to open Strawberry Hill, and we thought if we could just even donate workout equipment for Strawberry Hill, because Carl loved to run, he was athletic, so that was kind of our that was our immediate goal.
I don't know where I was the other day, but it wasn't down around here, but I saw a big green Carl's Cause banner hanging on a fence somewhere.
Yeah.
So I was like, there he is.
Yes,
there
exactly.
He is,
Yes.
spreading the
103rd,
word. I just wanted you to know that his name is out there and
It
people
is.
see it and
Yes.
remember it. So Stacey, I'm glad you're here because you know Bob and Kelly, you know how this money is being used specifically. We've heard of nurse navigators for cancer care. They've been on our program, but can you explain what a behavioral health navigator is?
Absolutely. Yeah, so thank goodness that you did decide to raise money and all that, and the specs have been awesome with funding this program. Basically what a navigator does is that you referenced earlier that you were confused, you didn't know where to go, how do we figure out what Carl might need? And that's really what the Navigator program does, because we have a community full of various mental health services for various different things. And it can be horribly confusing, and particularly for patients that we have brought into Strawberry Hill or Marillac. They're stabilized, they're not in imminent danger, but now we discharge them. And where do they go? What do they do? How do they get services? Because now they need an anchor out in the community. And so our navigators help those folks to figure out what the services are that they need and to get really connected into those services.
How did COVID impact your job?
You know, COVID was difficult just because a lot of things, obviously it was hard to do things more in person and to sometimes meet, but we got innovative with the rest of the health system with telehealth and really worked with our patients to meet with them over the computer. And link them up through Teams meetings and Zoom meetings with providers, and really did it that way. So
let's talk about the work that you all are doing, because I want to read a comment from someone who utilized the behavioral health navigator. This is the quote: "We had several positive impacts from the BHN program. Our navigator has helped us navigate in times of crisis and help prevent a hospitalization. She also helps find resources that we need to help our family set up for success in the future. I couldn't imagine navigating the mental health system without her. It's a big, big system, and the word navigation is key there." So Kelly, what's hearing that feel like to you and Bob, knowing that the work that you are doing, those golf tournaments and all the outreach that you're doing in the community is actually having a real impact with people like your family?
Yeah, it's amazing, and I mean, really, the credit goes to University of Kansas Health System and the Behavioral Health Department. But we were talking right before we started, and I was telling them a friend of mine's husband had a cardiac situation where he had a navigator, and he talked about how much that navigator helped him when it came to getting his care after he left the hospital. And I thought to myself, why couldn't we have had that? Or what a difference it would make for someone whose brain isn't helping themselves, to have someone navigate. Who needs it more than anyone? So when we were approached with that idea to fund a navigator program, first it was going to be a navigator, and now
Three.
Three.
So a complete success, Stacey, as you see it?
Absolutely. I cannot imagine doing this work without that. I think that one of the things that makes your heart hurt when you work with patients inpatient is that you know that you're discharging them and that you try to connect them, you try to give them resources, but like you said, your brain's not always functioning, Our patients are stable, psychiatrically stable, but they're still fragile, and so to be able to take them and to move them into the outpatient world, into the outpatient services, and get them the help that they need and really connect them so that we feel that they're more anchored with their mental health services, it's really, really good.
Great work. Dr. Douglas, from your standpoint, how important is this program?
This is really kind of the next step in helping us transition from inpatient care to transitioning successfully to outpatient care, especially for some of our most vulnerable patients. We have behavioral health navigators who are working with our adolescent population as well. And it's, incredibly successful in our ability to keep kids out of the hospital, because we want kids to be home and with their family, which is where they belong, and being safe. And it's hard because, as you're alluding to, for cardiac care or cancer care, there's often a navigator. for mental health services, the services are disparate. Even the insurance compensation could be a whole different system to try to get compensated or get that care.
Right.
So you need someone to walk you through it. Even if you are doing great, if you are a with it mom or dad trying to get your kid care, that's a full-time thing. Imagine if you're 20 trying to do it by yourself.
Well, they always
while
say,
you're getting over a bipolar episode.
they always say be your own health advocate. That's not always easy.
Yeah.
You know, when
Yeah.
you're the one struggling with
Yeah.
the health issue. So
Right.
you need someone to carry the load, Stacy. So thank you for doing that, you and your team. We have a lot more questions coming up for our guests. If you're watching live, be sure to ask your questions. Use the chat on YouTube or Facebook. You can email the Medical News Network. The information is there on your screen. Dr. Douglas, some people say that they don't want to talk about suicide, especially with little kids, because they're worried that it might plant a seed.
Okay.
You have said that's not the case. Remind us why it's not, and that it is okay to talk to kids about
Just
suicide.
be really quick. It's an understandable fear. It can feel strange. It can feel unusual talking about things like suicide with anyone. It's not part of our normal discourse, but it's absolutely been demonstrated. You can ask questions about death and dying and suicide, and you're not planting a seed. You're increasing the chance that you're going to save their life. And the way you can phrase the question, depending on what's going on, you can ask simply, are you thinking about killing yourself? That's okay. If you want, depending on what the situation is or the child's age, do you ever feel like falling asleep and never waking up? And if you're getting a positive response or a long dramatic pause, there's something going on and further inquiry is necessary.
So I have an 8 and 11-year-old. What are those conversations supposed to sound like?
So an 11-year-old, depending on what's going on, it could very well be like, are you feeling sad? Do you ever feel so sad you feel like you just don't want to be here? Do you ever feel so sad you just want to like lie in bed and never ever get up? Those are some ways you can start those conversations. And 11-year-olds, unfortunately, we've seen, and we'll show the data on it, the 10 to 14-year-old age group, when I started my training 20 years ago, suicide wasn't a concern because the statistical chance that a 10 or 11-year-old was going to die by suicide was very, very low. The numbers are increasing. So now when I see an 11-year-old and they're indicating that they're thinking about dying, we're going to take action.
Or they're just even in a funk. You're concerned.
Sure.
I've shared this story before, and I'm almost 50. And when I was 12, I had a 12-year-old classmate take his own life, and it was absolutely traumatizing, and it has stuck with me ever since. Now I have an 11-year-old who comes home and says things like, someone made fun of my eyebrows, and she goes in and shaves her eyebrows off. And, just having mom say things like, oh, you have beautiful eyebrows.
Right.
They're just jealous of
Yeah.
your eyebrows. It's not enough. And so I sit downstairs and wonder, should I be checking on my kid?
And you can do part of the check-in, and because we don't need to. We want to normalize things. Hey, are you doing okay? Check in. Do all that good mom stuff, and checking in with your kid, but also do that safety check, right? Is this to the point that you're actually in a not just a funk, but you're at the point where you're thinking about like you don't want to exist?
And ask more than once.
Ask more than once.
Keep asking.
Yes.
Okay, so Stacey, CDC data shows that more than half of suicides involve a gun. Do you think something as simple as gun lock or safe storage can prevent suicide?
Absolutely. And the reason for that is that it gives a chance for particularly a child who can be impulsive, but even for an adult, it gives that space between the emotion and the thought and the action to kind of be able to give them a place to think about that.
Those are the roadblocks we want to see, right? Yeah.
Because if you have to unlock that gun, or if you have to get into the safe and do the combo, or go find ammo that's stored somewhere else in the house away from the gun, then that gives you that space to really think about that. And for some protective factors to come into place, like you see your dog, and you're like, I love my dog. I want to be there for my family, or whatever that might be. For kids in particular. And the kids, hopefully, don't have the combo safe, the combination to the safe. So they can't get, it's means restriction, and they can't get access to their means. So,
Dr. Douglas, the U.S. Surgeon General calls firearm violence a public health crisis. Guns are now the leading cause of death for people ages 1 through 19. If we look at...
Let's pause on that.
Yeah,
one.
let's pause.
Let's pause on that. I'm being a little...
Yeah.
Coffee's kicking in. Like, the leading cause of death is something which is a preventable cause of death.
Yeah.
Right? And it's... We had a graph or something, but it's changed. So it used to be automobiles and motor vehicle crashes were the leading cause of death in this age group, and now it's gun violence, and that's both homicide as well as suicide, both. And so we can solve this. This can get better, This should not be accepted as a baseline status for our country.
You just said it. It's something that's highly preventable. And if we look at recent report from Surgeon General between 2012 and 22, over that 10-year span, there have been double-digit increases in firearm-related suicide, with the biggest increase among young people. What does this stat mean to you?
So those are people. So, and that's on right now?
Yep.
So we're looking at 68% increase, and that's the 10 to 14 age group. So we're saying 68% increased chance that a rate of 10 to 14-year-olds dying by suicide. And somebody coming, can you go up with the 15 to 24, 25 to 34? And really all age groups are going up, but most prominently our youngest and most vulnerable.
My heart is beating very hard. I'm seeing 68%, and when you have a kid that falls in that age group, it is absolutely frightening.
Yeah. And so what we're talking about, both in terms of screening for evidence of depression or suicidal thoughts, we're also talking about the big concept of means restriction. I know I'm going a little off script, but means restriction is really the big concept here. You know, some people will have this idea that if you get rid of one means of a person dying by suicide, they're going to find another. And that's been demonstrated multiple times to not be the case. Suicides commonly happen during a time of crisis. It's during a time when they're manic or severely depressed, or they've recently abused substances. And that's a time-limited event. So if we can make sure they can get through that event and not have access to the highest means of suicide possible, we can get them through it and get them help, and they're alive.
So my kids have been paying attention to a story that has gone viral. A 13-year-old girl in Mississippi, Aubrey Wyatt, bullied, ended her life last year. We know this new school year has started. Dr. Douglas, are there warning signs, as you've been talking, you know, about some of these things? I know you're saying the check-ins, and it's okay to talk about.
Yes.
Tell us more. What else do we need to know as parents of young people?
It's so hard. Because that's what we're talking about. Like, we don't want to psychopathologize every single normal developmental process.
Oh, but I do.
Right?
But we do. We do.
So, because that's often the feedback's like, oh, so now every single time a child is, you know, feeling bullied or whatever, we're supposed to immediately run for psychiatric. But we can do the screening, and you can keep asking. Because oftentimes, I don't know this case specifically, but we can ask, and just like when you start getting that first inquiry, when you're getting like, hey, more, you keep asking, and you start getting some help. So it should be, if you're talking to that young person and they're like, yeah, I'm kind of feeling down. Okay, let's take it up a notch. Let's go see the school counselor. Let's make sure the school counselor's not available. Let's go see the pediatrician. Let's get some more help involved.
But with social media and even there was a show streaming on Netflix, I guess, that people were, parents were, what was it?
13 reasons, yeah.
Yeah, and just the social media
effect,
the social media story that my kids were following. I mean, I'm just being honest, when they came to me and they were very detailed about,
just want to hit delete.
Oh yeah, and it was like, part of me was like, I appreciate they really cared about this girl that they didn't know. They were really fascinated by her story and felt empathy. But they were also talking about the means in which she had passed, and so I was kind of like in this thing of like, okay, what are they supposed to see and read, and are we supposed to just brush it off and move on, or do I stop and have the big conversation? Or
big conversation.
Big conversation.
Have the conversation.
I knew you were going to say that. Darn
have
it.
the conversation. Brush off versus have conversation. I'm generally going to go have conversation.
Oh, okay, I knew you'd say that. I knew you'd say that. We're talking about Carl at 27 years old, but when you hear about what's going on now, that 68% with 10 to 14-year-olds, as a mother, what are your thoughts?
Well, I guess I just think about awareness is kind of our biggest, the word that comes to mind, just because if we can talk about these things and normalize the conversation, just like you're saying, normalize it. When these things come up, just and some of the things like we've done even with Royal Stadium, we've had people talk about how it gave them an opportunity to have that conversation with their child, because they had them at the game and we were doing mental health awareness on the stadium level at Royals, and people came and said, you know, I would not have had that conversation with my 12-year-old if they didn't ask, why are we here? Why is Carl's cause? What, you know, who is Carl? Why are we doing this?
What do you feel when people say, who is Carl?
Yeah, it's just, it's loaded, you know, it's, I mean, you know, we were very proud of him, and I know what we're doing is something that he would want us to do, because that was the kind of guy he was.
Proud of him then. Proud of him now, and what he is doing. lasting.
Yes.
This is his legacy. You know that. So what do I ask everyone? Stacey, I'll start with you. We know suicide, big, complex problem. We could talk for hours about this. And we know that many factors are out of our control. But that being said, what can we do to help turn the tide against the crisis from the job that you do, what you see, and the people you impact?
You know, it kind of goes along the lines of destigmatizing, you know, honestly. And I think we're seeing a push, particularly in the media. We're seeing a lot of stuff out there about that mental health is health, you know, and to have those hard conversations, and it's okay to not be okay. What is not okay is to not get help. And I think the more that we educate and normalize and get it out there, I think the better off we're all going to be. And we're going to have those conversations, and parents are going to have those conversations, and spouses and everybody else.
And I asked you about COVID because I think it was that collective mental health issue that we all kind of said, hey, are you okay? I'm not, are you? And it really kind of bubbled things to the top, I think. Caused a big bottlenecking of getting people help, I think, but at least people were talking about it and supporting each other. And then you have celebrities coming forward, social media being used in the right way to say, hey, it's happening with me. I know it's happening with everybody else. What do you think the answer is?
Well, I always think, you know, let's get this problem, let's work on it upstream. Let's get more information to children and adults and families about mental health. Let's get, before we get to the crisis, you know, because I don't know how you prevent suicide. I honestly do not know. I don't know what that answer is. But I do know mental health is an important topic, and exactly like you said, during COVID, everybody experienced anxiety. I think everybody, you know, you could not watch the news and not have anxiety. But so that helped open that conversation a little bit. But I think, yeah, bottom line is we just have to have the resources. We have to help get people what they need before they get to the crisis situation, and make it a very open conversation, normalize it, talk about it. You know, we need to keep bringing it to the stadium level and keep showing up, you know, at all events. I mean, I thought about it last night with the Chiefs game. It's like, gosh, you know, just a little behavioral health moment.
Right.
Look at all the people you would reach. So it's important, and we're going to keep working on that.
Dr. Douglas, you're the doctor at the table. Do you have all the answers? Any of the answers?
No, I haven't.
What is the answer? She said, I don't know how to stop it. No one does.
But I would just kind of reiterate some of the themes that we've been talking about today as sort of two big points. One, means restriction works.
Yes.
So if there is a person in your life and you are worried that they are at risk of harming themselves or dying by suicide, removing the firearms from the home, removing access to a lethal means, will help save, doesn't guarantee it, but can help prevent them from dying. So if they're worried about them having access to, if they're talking about dying and there's a firearm in the home, lock it up, ammo separated, make sure they don't have access to the firearm. And that's talking about legalization or not, or any of that.
Right.
But if you have a child or a person in your life and you know they're in crisis, you don't want to have a method for them to die right there.
No.
That's it. And then two, just making sure with the idea of normalization of mental health, just like any other health condition. So when you keep talking about checking in, I was thinking of an analogy. If you had a child with asthma, you'd be checking on the breathing every once in a while. They go and playing sports. Hey, how's your breathing? Oh, it's okay. Doesn't sound okay. Let's ask some more questions. You might have them do a little bit more assessment. It's the exact same thing. If you have a child dealing with some sort of psychiatric issue, or you're assessing for depression, you might ask about their depression things. And if they don't, the answer doesn't make sense, you're going to have more of a conversation.
Have the big conversations,
Yes.
as you told me to do. I will do it. So, doctor's orders.
There you go.
Let's get to some questions. I got a couple I want to get to here. And Gene has a question and a comment. He says, very important program. How do you keep social media from making these mental health situations worse? We touched on it. Stacey kind of sat back. What I'm going to ask you, what is there? What do we do?
I wish I knew the answer to that, honestly. I mean, it's hard because, you know, one of the things that I do a lot of different teaching things across the health system about mental health and various mental health subjects. And one of the things I talk about is social media is it's our biggest enemy and it's our biggest friend. It's our biggest enemy because, unfortunately, it's unfiltered. It's not edited at all. And anybody can say anything, and it doesn't really matter what their knowledge or lack of knowledge is. And once it's out there, it's kind of like toothpaste, right? You squeeze toothpaste out, you can't shove it back into the tube. It's out there. So you know, the main thing that we can do with that is then to take our social media platforms and to give people facts, to let people know what is reality and how we can help. It's also a good platform to be proactive with coming out and educating, because again, that reaches a large number of people.
There are some good things about social media. You just gotta,
absolutely.
they may be few and far between, but it can be a good thing. Jeremy has an important question. If you do have that chat with your kids, Dr. Douglas, and you do get an answer or response that sounds like something could be wrong, what's the next step?
You're going to try to assess what level, how imminent the concern is. So, whoa, are we in danger right now? Do we need to go to an emergency room or immediately to a mental health center for further assessment? Or do you have time to safely take the child in the next day or the following days to go see your therapist, pediatrician, or provider?
I had a friend, a female friend of mine, take her life 2 years ago. But Stu has a question. He said he heard that most victims of suicide are men. Is this true? And why is that?
So the rates of suicide are increasing for all groups. And so the data over the last 4 years, we're seeing a significant increase in both female as well as male. Generally, men will die by suicide at about 50% higher rate than females, depending on age group and such. So there's some specific factors. One of the concerns there is means. So men often die by suicide by firearm. And so
There it goes back to your
there it
point.
is. I mean, that's
Much more lethal means.
It's a much more lethal means.
The means.
And
Okay,
so
that's kind of the common thread I'm hearing
that's the common thread.
through the conversation. Again, preventable in so many ways. So Stacey, I'm going to start with you. What do you think the big takeaway is from this conversation today?
You know, I think it's kind of what we were talking about a little bit about, that it's okay not to be okay. Everybody from time to time is not okay. It really, we need to get the word out there that mental health is just health. You know, which is just, I'm kind of reiterating what we've already said, but mental health is health. It's no different than asthma. It's no different than diabetes or a heart condition, that kind of thing. And we need to be checking in on one another. We need to destigmatize. We need to get that information out there so that people are having those tough conversations that Dr. Douglas has been talking about, and be there for one another and connect with one another and care for one another.
Thanks for the work you're doing. Much appreciated.
Yes.
Dr. Douglas, what's the big takeaway?
Big takeaway is mental health is health. Means restriction is an effective way to decrease the chance that someone's going to die by suicide.
Kelly, I want you to give us your final thoughts and leave us with just a good lasting memory of Carl.
Oh. Well, Monday will be our 7th annual golf tournament for Carl's Cause, and it's always a beautiful day at Canyon Farms Golf Course. We gather a great group of people, friends, family, and people in our community that really care a lot about the cause. That every year when I look around, I always think, you know, Carl should be here because he would have loved it, you know. So it's always kind of bittersweet, but it's, you know, we feel good about what we've been able to accomplish, and I know that's what he would have wanted to do. And he was very athletic and smart and had friends, and, you know, it's just like, he should be here.
Well, you can come back anytime to talk about Carl.
Thank you.
And talk about the great work you're doing. So thank you so much.
Thanks.
Thank you.
Appreciate it.
Thank you to all of our guests. Thanks to our viewers for being with us today. And please know that help is available. If you're in crisis right now, you can call or text the 988 hotline to speak with someone at any time. So thank you so much for joining this very, very important conversation. We know it's a heavy topic. So we're going to end the program on a little bit lighter note today. Kansas City Chiefs linebacker Drew Tranquil and his wife Jackie recently visited some of our pediatric cancer patients. They delivered joy jars full of fun. Take a look.
You have somebody here special to see you.
It's like a party in here. You guys got it all decorated up.
It meant the world to have Drew and Jackie come visit us today.
The fact that they're going through something like this and they welcome in strangers like us, they fill you with joy, honestly. Should we play a game of Operation? Oh, he's waking up from surgery. I'm gonna go for, ooh, the pencil would be hard. What in the world? Coda, you like presents? I met the Reese family when I was out with the Chargers, and we've kind of just stayed in contact, and they're sending joy jars all across the country now, and really excited to just bring them here to Kansas City and see these kids and see the smile on their faces. Hey, Elijah, what's up? Can I give you a little something? A little prize? There's some toys, some goodies in there.
Oh, that's easy.
That's easy to open. Look at you. Yeah, Jessie had a super cool story. Here's Jessie, actually. There she is. And during her battle with cancer, she'd like go hand out these joy jars in the hospital. And kind of her motto was never ever give up. Tegan's giving me a few elbows to the ribs and elbow to the gut. She's a tough little cookie. Okay.
Over here.
All right, let's do it. I'm excited to see this machine. It's new technology. Look at that. Look, it's an honor. Jackie, it's an honor. Do you like my look better or do you like?
I just think that is.
What, is that a better look for me? What in the world? Look at this mask. Can I take this home, please?
No.
No, I'm kidding. How do I look? She knows what she's doing. She's not scared. All right, are you ready?
Not at all. Okay.
All right, here we go. So that gets them in the perfect position every time?
Yep.
This machine is so intense. Like there's so much information and stickers and wow, look at that thing rotating. Oh my goodness. And this is the Yin Yang twins. This is what she likes to vibe to. All right, I think we're good. You live here inspired at their resilience and their ability to overcome. It's a blessing every time we get the opportunity to come. Yeah, you're vibing in here.
Coming up Monday on the Morning Medical Update. Tracy Edmondson could feel something wrong, but it took months to finally learn that it was ovarian cancer. I'm Jessica Lovell on the next Morning Medical Update. Tracy's path to diagnosis and story of survival, plus the non-specific symptoms that should be on your radar. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.